We don't have we don't have a screen over there? Oh. Oh, good. Great. Thank you. Okay. All right. Well, I guess I'll just start off.
Okay.
Welcome to our first speaker of the session. Can we start?
That's not the
Okay.
right talk either.
Oh boy. Yeah. All right. I think you're supposed to be moderator too. Yeah, you're a moderator too. Because we have co-moderators. So we can make comments. Sure.
Sweet. We'll moderate, sure.
Yeah, I think it said co-moderators on there. So.
You got it. Where are you sitting? I'll steal your seat.
Oh.
I'll sit here. We decided to do the party up here.
I like it.
Yeah. We're
Okay.
partying.
Yeah.
Oh, we've got the
Direct
crowd.
line.
We've got the
All
crowd
right.
for sure.
Thank you all, and welcome to our first speaker of this session. We have Dr. Betty Tong, Associate Professor of Surgery from Duke, who's going to share some information with us and an update about lung cancer screening. Thank you.
Hi, good morning. These are my disclosures. I have three main objectives today. We'll quickly go through the background and rationale for low-dose CT scanning and lung cancer screening. And really, we'll dive into the status of lung cancer screening in 2020, talk a little bit about utilization and appropriateness in areas where we can improve on what we're doing. And then I'll talk about some of the latest research and newest developments that will help us reach our goals. So I declined to PowerPoint a picture of the Clint Eastwood Good, Bad, and Ugly, but this is our checklist here. So the good news is that lung cancer mortality is on the decline, and low-dose CT scanning is an effective means for screening for lung cancer. This article hit the lay press a couple of weeks ago, marking the fact that the mortality rate from cancers in the United States is on the decline, and the two solid tumors that they called out in their article were lung cancer and melanoma. In terms of what's making it better, they describe imaging technologies, minimally invasive surgery, and immunotherapy as the main drivers for this. The article upon which this, the press article was based is this coming from the American Cancer Society. And these graphs, I think, are familiar to all of us, but I want to highlight the fact that in 1990, that was the peak of lung cancer mortality, certainly in men. And since then, and in women as well, there's certainly for men, there's been a 50% decline in lung cancer mortality since 1990. So we're making progress. And again, the authors of the technical paper wrote about the fact that there's potential for earlier diagnosis that leads to earlier stages at diagnosis through screening mechanisms. So it's been more than 8 years now since the results of the NLST performed here in the United States were published, and since then the European trials have helped to bolster and really cement the use of lung cancer screening in high-risk populations as effective for reducing lung cancer-related mortality. The results of the Nelson trial were discussed at the World Lung Cancer Conference in 2018. They demonstrated an overall 26% mortality decline for the high-risk population, as you can see here. The Italian trial, the MILD trial, demonstrated a 39% mortality reduction at a long-term follow-up of 10 years. I will note that what I consider to be the companion to the NLST was the PLCO trial, and that was a trial done in the United States looking at chest x-ray versus usual care in 150,000 patients. There were 74,000 patients in each arm, and chest x-ray was not effective even in the high-risk populations. So we know that low-dose CT scanning works, chest x-ray does not work. So unfortunately, however, overall the utilization and the uptake of lung cancer screening has been fairly poor. And in those populations where we are doing it, there is a fair bit of unnecessary testing and indeterminate findings that reduce the cost effectiveness of lung cancer screening. This study looked at the National Health Interview Survey in 2015. As a reminder, the national coverage decision came out in February 2015. These authors estimated that nearly 7 million people were eligible for lung cancer screening in the United States. And by their analysis, less than 4% of people who were eligible actually underwent lung cancer screening. And that was no different from what they had calculated for folks in 2010 who were also screen eligible. There was no difference in screening in different sociodemographic groups. And importantly, over half of the smokers who met criteria for lung cancer screening were either uninsured or underinsured with Medicaid. This is a study that my colleague Tina Taylor has done looking at the Medicare population in the United States. The heat map shows calculated lung cancer screening eligibility based on smoking statistics based on their census tract. And you can see the differences here. Overall, about 4% of the population was screened. Now, this is 2016, so the year after the NCD. There are regional and geographic variations in screening utilization, so we went from the range here is 1.4 to 15.1%. Thank you, Leahy Clinic, for what you do. Highest rates of screening are in the Northeast, and lowest rates of screening are in the South. I think there are many reasons why patients who are eligible aren't being screened. Certainly there are many provider factors. Primary care, which is where some people think screening should be, either don't know about the guidelines or don't know whether a patient is eligible. There's some who don't believe the data. One of our own pulmonologists at our institution wrote in a progress note that he essentially didn't believe the NLST. So we have education all around to do. There's a lack of awareness about certain programs and where to refer to. And the bottom line is it takes work. It takes time to do the shared decision making with the patients and to assess a patient as to whether they're screen eligible. On a patient side, I think there is a lack of awareness about lung cancer screening. We know everybody, I think if we fill the room with lay people, everybody would know that October people wear pink ribbons and that's for breast cancer. I'm not sure that you would get the same level of awareness about white ribbons and lung cancer. I think there is a proportion of patients who are actively opting out of screening. Either they don't want to know if they have lung cancer, they're scared of the findings. There are some studies demonstrating that people who are actively smoking are less likely to participate in health maintenance and screening behaviors. It does take time away from work, from their jobs, from their families. In our institution, they have to pay to park, to put their car somewhere and get their scan, and that all adds up as well. I think there is also a lack of access to either facilities and programs, both geographic as well as insurance coverage. With the premise that travel burden has been shown to be associated with higher stage diagnosis for both colon and breast cancer, Dr. Taylor and I looked at census tract level estimates of smoking behaviors and mapped them to, by distance to an ACR accredited CT facility. These are not the lung cancer screening centers of excellence. This is any CT scanner that has been accredited by the American College of Radiology. And looking across the United States, you see that there is wide variation, again, in distance to a scanner. The good news is that about 82% of screen-eligible people live within 30 miles of a accredited scanner. You see in the darkest areas of the map, however, that some patients live more than 200 miles away from a scanner, and I would posit that that's a pretty large deterrent. When you think about access and insurance, nationally the rates of smoking are about 19%, but we have a disproportionately high number of folks who are either uninsured or underinsured who are current smokers who would otherwise qualify for lung cancer screening. This study was published about a year ago by the American Lung Association looking at Medicaid coverage and lung cancer screening, and you see that the states in orange are those in which Medicaid does not cover lung cancer screening. So you've got a sort of a double whammy phenomenon here. For the states in green where Medicaid does cover lung cancer screening, these covered patients are subject to a myriad of additional requirements. Some have to undergo pre-authorization. Some have variable eligibility criteria, either USPSTF or Medicare or some other criteria that's not defined. And some of these patients are being charged for their scans as well. This is a study looking at the behavioral risk factor surveillance system. So this is a telephone survey that's conducted every year across the United States. And there's a standard bank of questions, but there's also different modules that can be added on. So there is a lung cancer screening module. And in 2017, there were 10 states that participated in this. These authors estimated screening eligibility using the USPSTF guidelines and found that about 14% of patients or participants who were eligible actually reported having a lung cancer screening CT. So we've gone from less than 4% in 2015, 4.1% in 2016 to 14%. So we're making some progress. Of all the sociodemographic variables associated with getting a scan, some of the traditional ones that you might think about were non-significant. Patients with some underlying lung disease, either asthma or COPD, a higher proportion of those folks did report getting a scan. And as you might expect, a higher proportion of patients who had insurance than those who did not have insurance were able to get their scan as well. So I think with all of this, there is significant opportunity for improvement. So as I said, the 2017 estimates are about 14%. When you look at screening rates for cervical cancer, breast cancer, and colon cancer, respectively, current measures are upwards of 60 to 80%. So I think what we'd love to see is, over the next several years, lung cancer screening being right up there. This study looked at complication rates and downstream costs, though. So all of the people who are opposed to lung cancer screening point to these downstream costs, indeterminate findings, and complication rates after lung cancer screening studies as deterrents for screening. This study was a market scan analysis. So market scan is a very large insurance-based claims database where they can access both inpatient and outpatient diagnoses. And they looked at the costs associated with diagnostic procedures used in a real-world setting, with the hypothesis that within the confines of the NLST, a very well-controlled clinical trial, that the real world was going to have complication rates higher than those reported in the NLST. Their study cohort included those 55 to 77. The NLST had definitions of 23 procedures that were lumped into 4 broad categories. The control cohort were patients who did not undergo these procedures. And the first thing that they looked at was age. And they found that compared to the NLST, seen in the lighter bars here, the incremental rates of complications after these procedures were higher in the real-world setting and higher in the older age group compared to the younger age group. When you look at the procedures, again, you see that the incremental rates of complications are higher than those reported in the NLST, and that the costs of these complications range from $6,000 for something minor up to nearly $57,000 for something major. And they concluded that, as they posited, complication rates outside the confines of a clinical trial are likely to be higher, and that age-stratified analyses may actually help to refine the cost and cost effectiveness associated with lung cancer screening. So here's the ugly stuff. We have very high rates of inappropriate screening despite level 1 evidence that it's appropriate in a specific population. This is a study, again, looking at the National Health Interview Survey, looking at 2010 to 2015 patient populations. We see that, as we discussed, there is a small proportion of folks who are being screened, and really not a lot different between 2010 and 2015. And these are patients who are being appropriately screened based on criteria. When you look at screening scans or screening studies that are being done inconsistent with these recommendations, so these are patients who met criteria but got a chest x-ray. And as we discussed, chest x-ray is not appropriate for lung cancer screening and not effective. And thankfully, the proportion of folks who got a chest x-ray in 2015 was smaller than those in 2010. And here are the patients who did not meet the USPSTF criteria and got either a chest x-ray or a CT scan. And you see an uptick in both populations in 2015 compared to 2010. And this suggests to me that there's a greater awareness of lung cancer screening as an entity, but perhaps a lack of knowledge in terms of how to actually get it done. All right, so there is a bright side. There are several advances and developments over the last year or so that I think will help us to refine screening as an entity and help more patients and help more of the appropriate patients. I think broadly these can be categorized into imaging and clinical. This paper also made the lay press last year, where the authors developed a deep learning model, so artificial intelligence, using the publicly available images from the NLST dataset. Basically, they fed the images to the computer that then provided some risk stratification in terms of a lung RADS category for these nodules. When prior imaging was available, so you had a series of studies that the computer could look at, if you will, it performed on par with a cohort of 6 radiologists, and these are academic radiologists in the study. Interestingly, though, when prior imaging was not available, the computer did better than the radiologists. So this led to an 11% decrease in false positives and a 5% decrease in false negatives in this study. So nobody go out and fire your radiologist yet, but I think that there is an opportunity here to help refine their reports and how they interpret scans. This is another study from the World Lung looking at radiomics. These authors fed, I think, 40 or 50 different imaging features into the computer, and here this was in sub-centimeter lung nodules, so the very small lung RADS 3, lung RADS 4A findings. And bottom line is that there was largely appropriate classification of these nodules on their screening exams. So we have an opportunity to better refine what to do with these small nodules that we see. There are several potential modifications to the lung RADS classifications that are being discussed by the ACR currently. Basically, it will mean that when the follow-up study is done, whatever finding there is gets reclassified, and the next study as dictated by that new category. In terms of clinical stratification, I think risk-based screening is really the next frontier. We all know these patient populations. The footnote in the guidelines does allow for consideration of screening in patients who would reach a greater than 1.3% threshold of developing a lung cancer within the next 6 years. One of the risk calculators widely used is the PLCO, or the Tamamagi calculator. This is a patient who came to my clinic. She, 16 years before I saw her, had had a left upper lobectomy, had had the appropriate follow-up, and then stopped following up. So by the hard criteria, she doesn't meet criteria for screening, but by risk stratification, she has a 4.7% risk of lung cancer within the next 6 years. She had a small nodule in her remnant left lower lobe. I resected it, and it was a T1N0 adenocarcinoma. So this study really gets to that. This is the International Lung Screening Trial comparing the risk model, the PLCO risk model, to the USPSTF. The bottom line is that the PLCO model is actually outperforming the USPSTF criteria with more cancers diagnosed and no difference in stage distribution between the two. I think the challenge with risk models is that you need more detail, you need patient-level detail. The PLCO takes into account BMI, education level, family history, personal history. So if we don't think we have time to do lung cancer screening right now, I think doing it with a risk model is going to be even more problematic. This is another interesting study, the BioMILD trial. This is using a microRNA serum marker in conjunction with the low-dose CT scan to basically put people into buckets. Green bucket says the low-dose scan is not concerning and the microRNA is low, not concerning. For those folks, they get 3 years in between scans. The middle category is that either the scan or the microRNA is a little bit concerning, the other is negative. Those patients got an annual scan. And on the right-hand side, the scan was concerning and the serum was concerning. They get a shorter-term follow-up. What the authors found is that the incidence of lung cancer differed among the 3 groups, as did the mortality. But importantly, there was no harm in having that longer screening interval for patients with the negative testing. So perhaps this is the future of lung cancer screening, that we stratify folks using a risk calculator. They get their scan and there's some radiomics or AI evaluation. Maybe the next step is a breath test. I show the picture of the dog because there's a Spanish group with a cancer-sniffing dog who's got a sensitivity of 97%. And maybe the dog can be used to help stratify folks and who gets that invasive procedure. So in summary, lung cancer screening is effective. That's been shown many times now. Utilization of scanning is behind that for other screening, and I think we have room for improvement there. And we need to better select our patients. Hopefully, some of these advances will help to better identify the patients who will most benefit from screening and who will be the least likely affected from the adverse downstream effects. Thank you very much.
That was such an excellent
That's
talk.
awesome. I feel a million
Wow.
times smarter than when I came in the room.
Me too.
Do you guys have questions or anything?
Oh my
Maybe
God.
time for one quick question?
That was such a great
I
talk.
kind of have a fun comment. So the good news, kind of about dissemination and teaching and things like that, actually on the general surgery in-service examination for the first time ever, they had lung cancer
I
screening
heard
on
that.
it this year. My sister called to tell me, she's like, you won't believe it, because I taught her about it. So
I heard that.
we're disseminating the information, which is
getting
great.
Okay.
Oh, that was excellent.
That was
Thank you.
awesome. Thank you, Dr. Tong.
That was such a good talk.
Under the airport.
I can't believe I have to follow her now.
Yeah.
Great. The token pulmonologist.
Thank you. That was really awesome.
Wow.
I want to know what we can do to mitigate the risk.
Wow, good morning. Thank you so much for having me. I can't believe I have to follow Dr. Tong. That was such a good talk. I feel like I'm so much smarter already. As the token pulmonologist, I'm here to talk about diagnosing the lung nodules, doing some of the stuff that I think you should know about. Whether you actually do some of these procedures or not, you need to be aware of some of the new updates. I give some educational talks. As far as disclosures, we'll talk a little bit about pulmonary nodules and then really focus on the navigational platforms. So Dr. Tong just gave a whole talk on this, so I don't think we really need to go over the fact that pulmonary nodules are an increasing problem. The more scans are performed, more nodules are found. But what does that mean? So worldwide, we get 1,800,000 new diagnoses of lung cancer a year. And when we think about mortality across the globe, 1,600,000 patients die of lung cancer a year. And that seems high, but there's a lot of people in the world. What does that really mean? Can we put that into context for us? Is that really that high? I guess it is. But if you think about it in terms of the US, 1 in 16 Americans will be diagnosed with lung cancer at some point in their lifetime. So if you think about just in this room, there will be about 6 or so of us that will have lung cancer at some point in our lifetime. And so that kind of brings it home a little bit more, and to kind of put a finer point on it, if you think about it, every 2.2 minutes, somebody is diagnosed with lung cancer. So that makes it real, right? This is important. And when you think about the mortality, today in the US, 422 Americans will die of lung cancer. So that's like a big jumbo jet. And we get, upset, it's all in the news when a jumbo jet goes down and hundreds of people die, yet this is happening day after day here in the US. And so, lung cancers, when they're found because of all these new scans, they don't come in these big honking masses. They tend to be small and peripheral and not very conveniently located, right? They're always located in these hard to reach areas. And so we're always stuck with, how are we going to do this? Do we screen? Do we follow them radiographically? Or do they need to be biopsied? Do they just need to be resected? And that's really kind of the focus of our multidisciplinary tumor boards, right? Does this patient actually need a biopsy, or should they go straight to surgery? Is there a way that we can tell if it's malignant or benign? Because really, obviously, you guys don't want to resect any nodule that's benign. You don't want to be resecting granulomas all day long. We don't want to be radiating infection or granulomas either, right? Are these patients even operative candidates? Although you guys have made major strides in taking less and less robust patients to surgery and getting them through, should we be taking these patients all for resection? And what kind of morbidity happens when you take all these people to surgery? And so our multidisciplinary conference really focuses on, kind of safety and efficacy. Should these patients go for surgery, or do they need a diagnostic procedure first? And when it's a diagnostic procedure that's decided on first, do we go bronchoscopy or do we do IR, so a CT-guided procedure? And that's where the safety efficacy balance kind of comes into play. So certainly with IR, you're going to have better efficacy, so your diagnostic yield will be higher, but at cost of higher rates of complications, so bleeding and pneumothorax primarily, right? And then you want to think about efficiency. So if you're biopsying somebody, if you go transthoracically and biopsy a nodule, you haven't looked at the mediastinum, and that's becoming more and more important as we approach our lung cancers and treatment. And so how does bronchoscopy fare? Well, when you look at large cohorts of patients, and these are all relatively recent, we think about nodules in two different sizes. So small would be less than 2 centimeters in size, large would be greater than 2 centimeters in size. And really, we're kind of so-so. And these have been really with older technology, so using virtual bronchoscopy, electromagnetic navigation, and radial EBUS really to guide us. But really, if our lesion is greater than 2 centimeters, our diagnostic yield is only about 70%. And if it's less than 2 centimeters, we do even worse, right? About 60%, 65% at best. And so, what are these things and what's improved to hopefully get us where we need to be? So virtual bronchoscopy is probably the older system. It's used a lot in Japan, not so much in the US. I think Northwestern is one of the few places that still has this. But it's pattern recognition software. So you take a thin slice CT and it creates an image of your tracheobronchial tree. And if you have a lesion, you can mark it on that scan and on that 3D tracheobronchial tree, and it will give you a pathway to it. But you still have to guide your scope yourself. So you have to be a decent bronchoscopist to get where you need to go. Using a smaller scope helps. So if you look on the left side of the screen, you see an ultra-thin bronchoscope, which is 3 millimeters in diameter. And then there's a thin bronchoscope, which is 4 millimeters in diameter, and you can see how much further out to the periphery you can drive. And so if you use a navigational platform, you can kind of drive and be more precise as far as your biopsies go. But that's, of course, at some cost, and the cost is the size of your working channel. So that's a 1.7 millimeter working channel is going to limit some of the instrumentation you can use to actually biopsy in some of your tools. But it does work, and so a lot of these studies came out of Japan. Like I said, they use virtual bronchoscopy a lot, and so if they use a small scope, virtual bronchoscopy, and radial EBUS to confirm that they're in the right location, they get diagnostic yields of above 70%, so pretty darn good. Electromagnetic navigation, does anyone use this here? There are surgeons that use it, yeah, good. Great. So there are two systems on the market, Superdimension and Varon, that work pretty similarly. So basically, you're going to create an electromagnetic field either with a board that sits under the patient or a pad that overlies the patient. And that electromagnetic field is going to create an idea of where different instruments are within the airways and the tracheobronchial tree. And it's going to correlate to a CAT scan that, again, you've kind of planned your navigation to a certain lesion. So here's kind of your CAT scan. You're going to mark in pink. You've got your nodule marked and located. And then it's going to create this 3D airway tree. And it will give you, several different possibilities of how to navigate yourself to that target lesion. So you can get a pathway that ends closest to the target. You can get one that has a better trajectory to get your angle right so that your instruments go straight into your lesion. Or you can use kind of different airways to see what works best for you. And then as far as yield, what helps to improve your diagnostic yield? If your lesion's bigger, so greater than 2 centimeters, better the diagnostic yield. If you have a bronchus sign, which is what's demonstrated here, so an airway that leads and ends in your lesion, you'll have a better diagnostic yield. If your lesion is closer to the hilum, if it's further from the diaphragm, and that's because as the diaphragm goes up and down with respiration, your nodule will move. And so in the upper lobes, your nodule will move less, so your diagnostic yield is higher. Obstructive lung disease, gosh, that sounds like a weird one. But again, if you've got significant COPD or blebs, your diaphragms are flattened, you're not going to have so much excursion, so your nodule will move less as you're trying to biopsy it. And then your yield will improve as you use multiple modalities, so a thin scope, a navigational platform, multiple tools to biopsy. And that's going to help you get where you need to go. I'm not going to go into a lot of detail about the different systems, but a couple of the things that you want to know is that the SuperDimension system uses these edge catheters that come at different angles to try and help hook you into the different airways. And then there's a tip track locatable guide that kind of works through these catheters. Once you get to the area of interest, you take out the locatable guide and you put your biopsy instruments through these. It works as like an extended working channel. And the evidence for SuperDimension is pretty robust. Actually, there's quite a few papers on this. It's been around the longest. And again, diagnostic yield rate around 70%. For the Veron system, their CAT scan, they do it in a slightly different way. So not just an inspiratory hold for their CT, they do it at inspiration and at exhalation so that they can try and account for the respiratory motion of your nodule. And their instruments, instead of having these edge catheters at various angles, their instruments are tracked. So the whole time you know where they are because of the electromagnetic field. And so that kind of helps you have a sense of where they are with relation to the nodule. And there's an application as part of the Veron system called SpinPerk, where if you don't get to your nodule bronchoscopically, you can actually do a transthoracic needle biopsy that's guided through the electromagnetic navigation system. And so is it GPS for the lung? Sort of. It gives you a route, but it doesn't recalculate, right? So like your car does, because there's no real-time imaging to say what happened to your nodule. Is it still where you thought it was, or did it move? And so we found in this study that as patients breathe, as they get put to sleep, as they de-recruit and atelectasis forms, the nodules can move pretty significantly, particularly in the lower lobes. And so I think this is how we're getting to our 70%, and we can't seem to get beyond that with current technology. This is the last of the older technologies. It's called transparenchymal nodule access. They wanted us not to necessarily be prisoners of the airway, and so it was using virtual bronchoscopy to find an exit point through the airway. So the red part is where you would leave the airway and you'd have a straight trajectory, not through any vessels, to get to your nodule and be able to sample it that way. But you go through lung or whatever else is there. Not terribly widely used. So those are the old ones. So now getting on to like what we're really here for, and the newer stuff is really, so augmented fluoroscopy or FluoroNav is a system by Medtronic, and I'll show you what that looks like. It's kind of an add-on to your electromagnetic navigation. They use it a lot in various centers, and it uses tomosynthesis to kind of correct and give you some real-time sense of where your nodule is now. So here, if you planned out your target, you can see on the top upper right thing, your instruments are actually pointing beside the nodule, not going to the nodule. And so what you want to do in that case is you're going to re-register. So you're going to take your C-arm and you're going to move it from an LAO to an RAO position. And basically, you're going to re-find your nodule using fluoro. And it's going to be an enhanced fluoroscopic image. So although you couldn't see your nodule on fluoroscopy initially, now you get an enhanced picture where your nodule will be accentuated. And so here you take like a 30-second, we call it a sweep. So you're going from LAO to RAO with your C-arm, 25 degrees to 25 degrees. And all of a sudden, you're going to see where your nodule is. It's going to be visualized on your fluoroscopic image. Taking a little longer than I was hoping. I didn't put the whole 30 seconds on, but now you can see your nodule there. And when you go back to your navigational platform, then your target is kind of resent so that you now are aiming towards your target. And you can see in the right upper hand box that your instruments are now pointing directly at your target lesion. There's another system called lung vision or body vision that does kind of similar things, again, using tomosynthesis. It accentuates the airways, and as you mark your target, which is in green, it's also going to mark your airway that leads to that target in purple. And so you can say, oh, wow, my instrument is not going in the right direction, so I'm going to reorient until my instrument's going in the right airway. And now that I see it's there, oh, oops, I've still diverted. Now I'm going in the right direction, and now I've found my way to the nodule. Yeah, and a lot of people are using cone beam CT. That's if you have access to that, which is really hard. It's expensive, and there's a lot of competition, at least at my institution, for this. But the cone beam CT can be used with other things. Here it's kind of shown with a robotic platform that we'll talk about in a minute. But basically, if you have these really difficult to reach lesions, so this one in the right apex, you can use your whatever navigational software to get there, and then you can see, you take this cone beam CT image, and everything's enhanced. You can see multiple generations of airways, and you can actually see your tool in your lesion, so you can confirm that you're actually there. And it's really nice. You get these really difficult to reach lesions. So one of my friends said that navigational bronchoscopy is like kind of being in the neighborhood. Like you're close, you're somewhere in the ballpark. If you use navigational bronchoscopy with FluoroNav, you're in the driveway. Like you're pretty much there. But if you use like cone beam CT and something like a robotic platform, you're in the garage. So you're really we're getting more and more precise as time goes by. And so, again, using multimodality treatments, you want to think about combining all of these things that you have at your disposal. So this group from Japan started using ultra-thin bronchoscope with cone beam CT and radial EBUS, and what they found was 40 patients. A lot of them had a bronchus sign, to be fair, but when they didn't use the augmented fluoro, when they used just virtual bronchoscopy alone with radial EBUS, their diagnostic yield was in the 70%, and then when they added cone beam CT, it went up to 90%. Same thing for a group from MD Anderson. They started using a thin scope with radial EBUS. Their diagnostic yield was about 50% for nodules, again, about 2 centimeters in size. After they added cone beam CT, their diagnostic yield increased to the 70%. And now people are starting to do all these different kinds of combinations. So now they're using cone beam CT with augmented fluoro, et cetera, et cetera. And so just to end, I wanted to end on the robotics. I think there's another session on robotics going on now that we're competing with, but we've got it right here. So there are 2 bronchoscopic platforms with respect to robotics. The one on the left is by Auris. It's got 2 robotic arms that guide your bronchoscope, and it's kind of a bronchoscope and bronchoscope system. So you have a larger diameter bronchoscope with a smaller one on the inside that can navigate more peripherally, and the controller looks almost like a gaming console. On the right, you have the robot by Intuitive. So I think most of you are pretty familiar with Intuitive. It's got a single arm. It's got a very small bronchoscopic platform, so it's about 3.5 millimeters in diameter, so you can really navigate quite far out into the periphery. And I think the advantages of the robotic bronchoscope are that it just stays absolutely still. So instead of me holding the scope, or God help me, my fellow who definitely moves, right? The robot will hold your scope absolutely still. So if you can get to the lesion, you're absolutely going to stay there as you kind of use your different instruments and tools to biopsy, and so you improve your diagnostic yield with that. And there's only very minimal data, but the first one in the Monarch or the Auris platform showed that they could get to 93% of the nodules. They did a trial called the REACH trial where they took 2 expert bronchoscopists, and the top panel of images show them driving thin scopes as far out into the periphery as they could get, and the bottom panel shows how far they got with the robotic platform, and you can see they definitely got further into the periphery with the robotic platform. ION by Intuitive, their first in-human study, was also quite successful. They got to 97% of the lesions with no significant adverse events, and their diagnostic yield was 80 to 88%. And so I think, with all of these things, how I look at it is, we're working to work together. So we want to get diagnoses for our patients who need them and try and collaborate with you guys. One of the things we do a lot at Northwestern is pleural dye marking and localization for your procedures, for your resections, to try and minimize you guys trying to find your nodules, especially the ground glass opacities, and we place fiducials. So with that, I'll just say that we have a lot of really exciting technology coming up, and hopefully that will start to improve our diagnostic yield as we start to figure out how to have ventilatory strategies and keep our patients still and keep our scope stable so that we can hopefully do a better job getting the diagnosis for you. So thank you so much.
Okay. And I do recognize that we're standing between you guys and lunch, so we're going to try to be efficient with this. I don't have anything to disclose. Yes.
I'm sorry. Dave Atway from Jeffries in Pennsylvania. You have a lot of expensive equipment to use to get out to very peripheral lesions. You're still saying maybe 80% at the best of diagnosis. I mean, my tumor board, we see something very peripheral. We have the choice of, biopsying it is sort of there, but even if a negative biopsy does not mean negative tumor. So typically we do wedge biopsies. And a lot of times I do that, I take that down and I look at it with pathology. It's a heterogeneous tumor.
Yeah.
So you could have all the radiology saying, hey, you're right in the middle of it. And you could be, and you're still not going to have the actual tumor. So do you feel like sometimes with these negative things, have you delayed actual treatment of somebody with cancer because, well, we have this very expensive equipment that says there's not a cancer, and you're like, well, actually it still is, you just misdiagnosed.
Yeah, no, that's a really good point and a really good question. I think for us, that's where a multidisciplinary tumor board comes in, at least in our institution too. For us, we use a lot of this stuff. The studies all show it going to these very peripheral things. And I would say most of those patients either go to surgery or transthoracic needle, but at least in our institution. Where we find it useful is the patients who are really not robust enough for surgery, or in those really difficult areas that are really inconvenient, that it's too close to some big vascular structure for IR to go for. It's not convenient for you guys. Maybe it's somewhere on the left, close to some of the structures that are harder to get like a good field for. And I think that's where these things come really into play. And they're kind of working towards hopefully getting treatment modalities, sort of like IR has been doing with ablation catheters and things like that for some of the smaller lesions for patients who won't tolerate surgical resection.
And I think that we're going to hold questions for right now because we're already about
Sorry.
almost 15 minutes behind. So for next questions, maybe we could wait until the following. Is that okay? All right. We're going to try to catch up a little bit and get you guys back on track to still get some lunch here. All right. Good morning. Our topic here is to cover preoperative optimization and recovery. There's been a lot on enhanced recovery pathways over the past few days here. A lot of incredible information, and I'm not going to reiterate all of that. So I'm going to focus a little bit more of this on the pre-op optimization and getting people tuned up for surgery. I have no relevant disclosures. The audience response system was not activated for this session, so we'll have to use the old-fashioned raise your hands. At your centers, how many people have a defined preoperative pathway for patients? Is anybody? Okay. Is it used, and raise your hands again if it's used in all patients? What about select patients? We have select. Or no patients, okay. And then what about post-op care? How many people here have an enhanced recovery pathway at their institution? Okay. Does anybody have no enhanced recovery pathway at their institution and they're looking to build one? Okay, great. There's some really good places to start with that. So preoperative optimization. We want to get people ready for surgery. There are surgical factors and patient factors that lead to risk. Some of these might be modifiable. What could we modify? In some people, nutrition. We know a lot about that from our esophageal cancer patients. Maybe not quite as relevant in lung, but it's probably important to some degree. Medical optimization with medications and disease processes, and physical activity with prehabilitation, and particularly smoking cessation, because tobacco use, yes, they already got the cancer, but tobacco use leads to increased complications and problems with any kind of treatment. So this logo, Strong for Surgery, anybody who's looking at preoperative enhancement, I would refer you to, this is a great site and great place to start. So there's all kinds of things that can lead into frailty, poor PFTs, they're weak. A lot of times it's the eyeball test. We see these people. My nurse practitioner sees them before I do and says, uh-oh, we got a tough one coming. And how much can we actually change and tune up before surgery? Even if we do tune them up, will it make a difference? So there's some data on preoperative physical activity. All right. If we give people a physical activity plan and we tell them to go walking, yes, they can walk a little further. Great. That says that we can actually change someone's physical fitness a little bit in a short interval time. We can improve the 6-minute walk distance. But patients don't come to me and say, hey, I want a better 6-minute walk distance. No. They want other endpoints. Our patients want other things. VO2 max, yeah, that's better, but that's also a surrogate marker for them just getting in better shape. The outcomes that we want and the patients want is length of stay and post-op pulmonary complications and dyspnea. And those are all better too with preoperative physical activity with a prescribed walking activity program. So we can impact some outcomes with physical activity before surgery. Smoking cessation before surgery is a huge challenge. Many patients have quit, but a lot have not. This just came out last week. The Surgeon General released a report on smoking cessation, and it's a pretty extensive PDF to download. There's a few points that are pretty key for us as physicians. Healthcare professionals, we can advise them, offer them brief counseling, etc. This right here with the arrow. Every member of the care team can help. This is not a doctor-only deal. Matter of fact, the doctor can guide it, but I would say that many people should be doing it besides the physician. Delegating these tasks improves efficiency and supports a coordinated care approach. And it's reimbursable, it can help meet quality measure. It is reimbursable, but not huge amounts. This 99406 is 3 to 10 minutes, and this is more than 10 minutes of counseling time. And 99407 is a whopping 0.5 RVU, but it is reimbursable. So how long do we get people to quit? Older studies hinted that there was worse problems with cessation, and that has been repeated and echoed. There's been a recent meta-analysis looking at it, and that did not really hold up to be true, that recent smoking is harmful. In fact, if somebody came to my clinic and said, yeah, I just quit smoking 2 days ago, I wouldn't tell them, oh, go ahead and start, right? So recent smoking does have increased secretions. Those cilia are waking up, the mucus is getting mobilized, the patients are coughing more, but that's okay. 48 to 72 hours, I know there's some people doing some magic and they're getting their VATS lobes home in 24 hours. Great. My patients stay in the hospital 48 to 72 hours. So they're going to be quit in the hospital anyway. So we don't want them to go through nicotine withdrawal and everything else on top of that. So I would say that we get them quit any time before surgery is beneficial. The longer, the better. Here's some key points from the Strong for Surgery. It's a great teachable moment. It's a point where the patient is focused on getting better. There's potentially increased secretions for the first few days, but other than that, it should taper down risks, and cardiovascular risks taper down too. So there's not a clear defined period where it's an optimal cut point of quitting. And it's probably different in different patients, with frail people benefiting more. So, okay, this is a cancer talk, so we're going to talk about a survival curve. Okay, that's not a drug. That's not an operation. That's not a treatment. That's people who've quit smoking and people who have not. Yeah, there's selection bias. People who quit smoking might be more motivated and other things, but this is no tobacco use, and this is tobacco use in all smoking at the beginning. It's a telephone survey, Roswell Park, and it was well done, but it showed a 9-month survival benefit. If the med-onc doctors had access to a drug that gave them 9 months, they'd be jumping around and we'd be buying the stock in that company. But no, this is quitting smoking, and it improves survival even when we adjust for age, pack year, and other things too. So smoking isn't just a short-term, less complications at surgery issue, it's a long-term survival thing. Okay, cessation is important, but how do we do this? It's difficult. These things echo that. Graham Warren and colleagues, both through the IASLC and ASCO, survey people. Online survey, self-reported, self-selected, self-reported, so it's probably more optimistic than what really is going on. But these are doctors, these are all medical oncologists, these have some surgeons and some radiation oncologists. They all say they ask about it, probably. They all tell people to quit, but less than half will say they'll even use medications and actively treat people. So there's this drop-off where we acknowledge it, we know it's a problem, we kind of ask about it, and then we don't do anything, all right? So a good framework for this is the 5 A's. Ask, advise, assess, assist them with behavioral counseling and pharmacotherapy, arrange follow-up. And there's not any one method that works perfectly for everybody. And this is time intense, and we don't have time for this. I don't know about you guys, but my clinic never runs on time. I've always got patients waiting, and I don't have the ability and the expertise to spend an extra 5-10 minutes talking with a patient about, oh, you quit before, oh, you used a patch, it worked pretty well, or no, you tried the gum and you didn't like the way it tastes. Like, I can't dig into all that because I don't have the time. I care, but I can't do it. So and this is more detail. Oh my God, I could never get through all this. This is awful. I could never address all these points. There's data intake forms and things we do, but there are people who are very good at this and people who can work on that. So we've kind of truncated this this 5 A's into ask, advise, and refer. Refer means there's other people who are better at helping people quit smoking than we are as surgeons. Toll-free quit line. It could be a passive referral. It's printed in small print at the bottom of their discharge papers. Yeah, you're referring it. It's not going to work. They're not going to call. Many quit lines, including ours in Arkansas, has automated enrollment processes where our clinic nurses can enroll the patients in the quit line and the quit line calls them. So it's more of an active enrollment instead of a passive information. Group counseling, American Lung Association does a great job with freedom from smoking, and individual face-to-face counseling is great as well. So this is a couple slides. One of our residents, John Pagtilian, who's sitting there, one of our general surgery residents talked about a couple days ago. This is a project we had where we got our patients in 2 different arms, or 2 different cohorts. There was the lung cancer screening and then the ones that were in clinic for surgery. And we use an opt-out method where we approach them for smoking counseling with the individual counselor at the point of care. And it was patient-tailored, digging into what works well for them and what doesn't, 10 to 15 minutes, and then telephone follow-up. And patients could opt out if they choose. Now, very few opted out. Most all of them wanted to talk. They already had to talk to the person anyway, who's the nurse practitioner in the workflow, who was the certified tobacco counselor. Our quit rates were not great with the lung screening program, 13%. We're failing 87. Wait, that's actually not that bad. Unaided cessation's 3 to 5%, right? Physician, like doctor telling the patient, it'll improve it a couple percent. So up to 13 is great. And we had not used pharmacotherapy here. Here, we had 45% quit, and that's a long-term quit rate validated with carbon monoxide. A lot of our patients use a combination patch plus gum. Think of a patch like a long-acting basal rate, and a gum is a short breakthrough burst of nicotine for craving. Lozenge is good for people who may not have great teeth for gum. I mean, we're from Arkansas, right? Sorry, I'm trying to make funny, wake y'all up. But all right, but overall, we can get people to quit, and we can get people to talk to counselors. So that's what we're doing and implementing that in the workflow to try to get people through surgery in a healthier way and getting them quit. The question comes up, will you delay surgery for quitting? How long does it take a lung cancer to grow to 2 centimeters? I don't know the exact answer, but I think it's not 3 or 4 weeks, right? It's months, maybe a year, longer. So getting somebody in a little better shape for surgery with less risk of complications, yeah, that's 3 or 4 weeks anyway. For our patients undergoing induction therapy with chemo or chemo-reds, yes, we're going to get them to quit smoking preoperatively. The question comes up, do you ever refuse to operate on somebody who's still smoking? We'll delay them. We'll give them their best shot. We'll counsel them. We'll tell them it increases complications. But I don't feel good about withholding a potentially life-saving treatment option from someone who's shackled by addiction. And I know there are some patients, some doctors who won't offer surgery, but personally I feel that if they have an addiction that they just can't overcome, that we should still offer them curative treatment. And that's just how I see it. So a little bit on enhanced recovery. And in the interest of time, because we're running late, and because this is extensively covered by really great talks here, I'm just going to clip through this. Enhanced recovery is a structured pathway. Many of you already do this. That's great. We know it shortens length of stay. We know it saves the hospital money. They take all that money and they reinvest it in all of our surgical clinics and our nursing. No, they don't. Yeah, but here it is. Post-operative opiates are less, which is wonderful. Fluid balance, which is also related to recovery and breathing, is great too, and that was from Linda Martin's initial study. But there's many points. There's a 45-point outline. Timothy Batchelor talked about this yesterday. It was great. It goes all the way from preoperative counseling, nutritional screening, et cetera, et cetera, et cetera. If you are looking for an ARIS pathway and you don't have one, this is a great place to start. Not every ARIS pathway is always the same, and you have to find what works well at your institution. Some things are more achievable than others. You can find that on that website. Quick case study, and then I'll hand it over to our next one. 64-year-old guy, smoking a couple packs a day. You know it's a couple packs because he's got 2 in his shirt pocket. He had a squamous cell cancer of his head and neck years ago. Lung cancer screening. Boom, we got lung cancer. Otherwise, we wouldn't be talking about his case. But he's got a great big lung cancer there, about 5.7 centimeters on CT scan. Initial was non-diagnostic, then squamous cell cancer. He looked kind of frail, didn't look great. We tried to bronch him and check everything, checked all those but nope, they're all negative. He's a surgical candidate, maybe. We checked some PFTs. FEV's 30 or FEV's 40, DLCO's 38%, and he said he's actually feeling a little bit better that day than his baseline. He has a productive cough. Can't go grocery shopping around the whole store on his own. He rides a scooter to grocery shop. Is this guy going to do great with a lobe? I mean, it's too big for SBRT, maybe chemo plus and then surgery. I could see a trach in a skilled nursing facility in this guy's future. So we talked with him and we said, you really aren't going to do well with surgery. And we do have a chance to improve things. Let's get your respiratory status. I have a clinic in the same place as our interventional pulmonologist. So we work very closely. Get him on some, he was on steroids. We tapered it off. We got him on bronchodilators. We gave him incentive spirometer when he's sitting down in the house, and we gave him a walking program, and he quit smoking. And of course it improved, and of course he did fine. Otherwise I wouldn't be presenting the case, right? But the neat thing is we took a non-operative, fragile guy who's like a scooter rider, and we actually optimized him for surgery. And he got some adjuvant chemo. And in follow-up, 2 years later, he had an adeno, a little 8 millimeter on the upper side, SBRT, done. He's almost 5 years out now with no evidence of disease. So, occasionally we can get that rare non-op guy, and we can convert them to an operative candidate. It probably has good impact in elderly or frail or people who are on the fence and getting them through surgery better. But I'd say even the strong, fit person may have a little fewer complications, or if they do have a complication, it won't hit them as hard if they do preoperative physical fitness activity and smoking cessation. So thank you very much. Thank you. If there's any questions, maybe we can take one quick one before we move to the next. No questions? All right.
Hello, everyone. This is our last presentation of the session. It's actually case presentations to facilitate discussions with our experts. And so really want you to participate, ask questions, shout things out, come up to the microphones, so we can really have a robust discussion. Here are my disclosures. So our first patient, 69-year-old woman, diagnosed with rectal cancer, underwent resection for that and is currently undergoing imaging follow-up. Up until this year, she's had chest x-rays, and now they decided to do a CT of her chest, abdomen, pelvis. Never smoker, very, very healthy, no pulmonary issues. So she gets her CT scan, and here's what they see.
Oh, is that an easy place to biopsy there, doctor?
That does not seem to be like an easy place to
So
biopsy.
what do you guys think? First time CT scan in the chest, what are your first thoughts seeing at this?
Well,
Who wants to do more imaging? What do you guys think? Show of hands. Who wants
Get a
more
PET scan.
information about these areas?
Yeah,
Do
definitely.
we have old images?
This
No.
is it, chest x-rays, and they're all negative. No findings.
There's 3 separate areas.
3 separate areas. And so what do you do with these? Is one more concerning than the other? Is there one that particularly that stands out to everybody? So looking back at these. Top one, middle, bottom?
I
Middle.
think the middle
Yeah.
one looks
The middle
most
one looks
solid and speaking
scarier.
to me.
Yeah. So what do you do with these? Repeat imaging, biopsy? Would you go straight to biopsy? Would you get another form of imaging?
I would say a lot of people would probably go for a PET scan, just because it looks somewhat solid, and
Yeah.
and maybe it's big enough, and you could get a sense of, is there anything in the mediastinum and
Yeah.
anything else that you want to do?
What are some of the radiographic
You said
features
colon?
that are helping to kind of guide your decision? It was rectal cancer.
Yeah.
So she had, exactly. So because she has rectal cancer, like that would be helpful.
Yeah.
Just, I think it's more solid, it's somewhat spiculated and irregular. The size of it kind of all makes me a little bit nervous.
Yeah. Does she have any recent history of respiratory infections or productive cough or anything that we
She
could attribute
does
that to?
not,
Okay.
and she walks on a treadmill 4 miles a day.
Okay.
Oh, she's an excellent surgical candidate. Just snip
so-
them all out.
So it's not like this is possible infection, but it could be.
So interestingly, in the bottom of her CT scan report was a copy of the Fleischner guidelines, including this blurb for multiple subsolid nodules, indicating management decisions should be based on the most suspicious nodule, which is great. But it also follows to say that if persistence is confirmed on CT scan after 3 to 6 months, then subsequent should follow the recommendations from the category of the most suspicious nodules. So she actually got additional imaging as the next step because this was actually quoted in her CT scan. So for those of you who would recommend a biopsy, which one would you go after? What would you do? Would you use CT scan? Would you use endobronchial approaches? Would anyone go straight to surgery?
I can't remember where that was. I think it was really
Yeah.
more peripheral, right?
It was on the right side, right middle, kind of an anterior right middle lobe.
Yeah.
I think
There
I'd
was
probably go
no-
after
yeah.
that most suspicious one.
Agreed.
With the hope, if we get something like a weird infection, we could perhaps write the other 2 off temporarily and do surveillance. But I don't know. I might go after the most suspicious, worrisome one first.
Would
Yeah.
anyone else go after a different one, and why?
I don't know what I'd do if it got cancer, though.
I know. The third one's easier to get. There was an airway going there.
Okay.
Agreed.
It's true.
Less
No,
than
no.
ideal.
Yeah, it's going to be a
Yeah.
percutaneous approach.
Yeah, absolutely.
But then if you go for that one that's like really ground glassy and they just see like chronic inflammatory changes, then what do you do, right? That's kind of an annoying one to go after. Because it's more ground glass. There's no solid on that one. That one looks more
Yeah.
like it could be more inflammatory.
And those axial images were all lung window, but on the soft tissue windows, is there a lot of adenopathy?
No, there's none.
Okay.
It's done. So I'm glad that you brought up the option for tissue diagnosis, and so going after the subsolid versus solid, and trying to make plans for that. Where are you aiming for when you're going after a subsolid lesion?
I mean, I try to go for the most solid component. That's usually the biggest bang for your buck.
I'm So glad you brought up the kind of thinking about how to go after the different
And we weren't
different
prepped.
spots. Let's talk a little bit about resection options. And so, let's touch a little bit on lobar versus sublobar. When you're seeing multiple spots in the lungs and you're worried about potentially multifocal problems, we know this patient has at least 3 potential spots right now. Should we be thinking about size differently? Should we be thinking about our approach differently? Should we be thinking about lung preservation differently? So who would advocate for lobar versus sublobar? And are you basing it on the solid component, the comprehensive solid and subsolid component?
Well, have we done a biopsy and
So
gotten
let's
anything back?
let's say we've biopsied the middle lobe one only, and it is a malignancy.
Ooh,
So we know that the middle lobes, the middle picture, is definitely an adenocarcinoma. The other 2 are as
Then
of
you
yet
could easily
unknown.
go after the lower one,
Yeah.
the lower picture,
Yeah.
and see if that's also malignancy, because that one's actually pretty easy to get
yeah.
to.
So we go after the lower lobe one on the left, and it is also an
A different
adenocarcinoma.
one?
Yeah.
They're
Or
both
same?
adenocarcinomas. We have small biopsies. They can't say with definitive that whether they are related or if they are unrelated. What's that?
The third one's in the right.
Upper lobe. Medially.
Oh, yeah. That one's super hard.
So that one was not biopsied.
Yeah, not
Yeah, but it's
surprising.
going to be. If you're 2 for 2 so far, I'd worry that number 3 would be positive as well.
Right.
I would.
Right.
Um,
But then do you treat them as synchronous primaries, or are they
yeah.
metastatic?
I think the most worrisome one is the one developing the most solid component in the middle.
Agreed.
And I'd probably be the most aggressive locally on that.
Yeah.
Whether that would be a VATS wedge or VATS lobectomy, I'm not sure. But I try to think of what would most likely kill this person and try to give the most robust
Right.
local treatment to that, thinking that if they tolerate it well, maybe we could do a stage surgery for something else. If they don't, we could do SBRT or a different ablative therapy for
And you could
perhaps the less
radiographically
aggressive ones.
surveil the less aggressive ones, right? So you could follow them and see if they change or become more solid, then act, like you were saying.
If you're already in on the right side, do you go after the upper lobe one or do you ignore it? Who would go after both right side at the same time?
Yeah. If you're already in that house, I'd probably
Right?
get it.
Would anybody not?
I'd probably wedge both of them off
Right.
if you're looking at it.
Yeah.
Is that what you did?
So actually we did a middle lobectomy for the larger one. It was actually quite proximal and involved with the vessels, and then a wedge for the upper lobe.
Good.
We've now actually addressed her left side in a staged procedure. But these cases, the more we scan people, the more we're finding, and it's not uncommon for us now to be facing patients who have multifocal disease. And sometimes it's on the same side, sometimes it's on contralateral sides, and trying to decide how to manage that can be a challenge. A lot of different people are starting to publish algorithms for how they're managing. And actually, I love this article because it's called the whack-a-mole strategy, with the idea that as new spots start to kind of raise their heads and transition from the pure ground glass, they start growing, they start developing these solid components. People are going in and addressing those. The dominant lesion, as everybody kind of was nodding and putting up their hands, is going to be the first one that you're going to address, and you kind of shape your care plan around that dominant lesion. So second case, more interesting and
Can I ask you a question?
yeah.
Okay, so what did you do on the left side blood operation?
Yeah.
Okay.
Yeah, so it was actually in a really, really difficult spot, unfortunately. So we had it we actually had it dye stained with the idea that we were going to see if I could do a complex segmentectomy. I did end up doing a segmentectomy, but I ended up having to take 2 segments to be able to get it. I was able to preserve kind of lateral and our superior segment, but it was a challenging spot because it was so proximal. I was hoping to save more lung in her, but thank you for that question.
And was the one in the upper level, was that a cancer patient?
Yeah, it sure was.
What operation did you do there?
She had a wedge resection for that one.
Okay, did you have trouble finding
I did not, because I also had that dye marked by one of my interventional radiologists concomitantly. So I actually wedged that out first and then proceeded with the lobectomy.
So if you would have done your middle lobe resection, wedged out the upper one,
Yeah.
I'm sure that you took out lots of great lymph nodes because
Took
you're a
out
wonderful cancer surgeon.
Lots of lymph nodes.
What if she had N2 positive disease?
Yeah,
Are
yeah.
you chasing after that left side then?
No, so I probably would not in that setting
Yeah,
have
I would
chased
be-
after that
I
left
think
side
you
right
back
away.
off because that's the
Then
driver
you're-
of her survival.
Yeah. I think these are challenging cases, and they raise so many important questions. Yeah. Yeah. So she actually did have another spot of undiagnosed cancer in that lobe. And I was trying not to go down the rabbit hole too far, but you're taking me there. So actually she did, and we didn't know about that until final pathology. But at that point, we had 2 sites of disease. She had recovered, 3 sites of disease on that right side. Rescanned her, took her to tumor board. She's this incredibly fit woman. Believe it or not, all of her pulmonary function tests were over 100%. She's a long-term, survivor from her rectal cancer, and so after kind of hemming, hawing, we actually got another CT scan. Her left lower lobe was continuing to grow, and so we actually decided to take her to the operating room at that point to address the left lower lobe. She's now a year and a half out. She's doing well, hasn't had anything else pop up in her lungs, but the reality is she's very likely to have something else develop at some point.
Yeah.
Oh, yeah, for sure.
I would argue that prior to doing any resection, since you've got the same histology on both sides,
Yeah.
you should get sample the lymph nodes first before invasive mediastinal.
Yeah, so she did have invasive mediastinal staging along with her biopsies. So she, anytime we're sending a patient for a transbronchial biopsy for kind of suspicion, when we have a suspicion that these are going to come back positive, we kind of have rows on site always. So we have a kind of prelim diagnosis usually, and we're checking adequacy of sampling, and we do concomitant mediastinal staging. Her EBUS was negative. They sampled stations 11, 10, 4, and 7 bilaterally, and all of that was negative. All of her nodes were also negative on final pathology when we resected
really
them.
EBUS.
If anybody was at Linda Martin's talk yesterday, there's a lot of conversations ongoing too about the adequacy of lymph node resection and how many stations we should be going to, how many lymph nodes we should be taking out. There's now, the 3+1 rule, so we should be going to at least 3 mediastinal lymph node stations, plus at least one N1 lymph node station. We routinely take our 10s, 11s, 12s, as many lymph nodes as we can find to try and help. Unfortunately for her, all of hers were negative.
Receiving adjuvant therapy as well, and the left side started growing. Is that
So she did not have any adjuvant treatment. When we looked at final pathology, everything was different enough that we called all of these independent primaries. So I think that's another really important topic to kind of pause and debate. How do we classify these? Are we calling them all early stage? Can we truly biologically prove that these are all truly unrelated when there's a significant amount of tumor heterogeneity even within one single nodule or one single tumor? I think it's really, really difficult, and I think it highly emphasizes the importance of having truly multidisciplinary discussions about these patients, having the pathologist present, having our radiologist present, having our radiation oncologist present, everybody together. So we talked about this patient for a long time. We actually even sent her for genetic testing because she has this rectal cancer. She's not very old. She has potentially three lung primaries. Haven't identified any kind of genetic driver for her. She has kids, so we're thinking about them and their future as well. But these are tough cases, and so I think it also calls for additional trials looking at these multifocal patients specifically, and drugs to help prevent recurrences. Should we be putting these patients on some kind of medication like canakinumab? There's risks and benefits to both arms, but it's such an important question. How would you, with slightly different biologies, would you call this all early stages, or would you call these metastatic? It's a tough one, right?
You want to
Yeah.
give them
Yeah.
benefit of the doubt, but at the same
I
time.
wouldn't be able to really argue enough to say, hey, you shouldn't get adjuvant therapy.
Yeah.
Yeah.
Um,
Oh, yeah, we're over
so
time.
sort of
Okay.
would be
Okay.
choice.
Yeah, absolutely.
Okay.
Kind of quick poll of the room before we wrap things up, since we've gone over time. Thank you everybody for staying. How many people would call this metastatic disease and treat it as metastatic disease? And how many people would try and treat these as multiple primaries?
I think I do multiple primaries.
Yeah, I think the trend seems to be more and more, especially when they're starting as kind of these ground glass opacities and developing the
This is not
solid
ground.
components, that we're thinking
It's
about
not
these more and more
They
as
all look
multiple
different.
early stage tumors. But it's a challenging discussion to have with patients. Has anybody changed their follow-up strategy for patients who have multiple sites of disease? And so thinking about more frequent scans.
Yeah.
Yeah.
Yeah, I think so.
I'd say 6 months
We do that a
minimum.
lot, like with our multidisciplinary conference, that we kind of adjust the follow-up so that it ends up being sooner.
And how
rather
frequently do
than
you do them?
later.
Are you doing them every 3 months?
I think we start at 3 and then we start lengthening, but
Yeah.
we don't go to like a year right away. It's always,
No.
3, 6, and then a year. We're just more careful.
She does every day. In fact, she asked if I could get her a treadmill for her room for after surgery. She's incredible. Yeah.
Man,
That's awesome.
I
wish
gotta move to
was like-
Tennessee.
Even
Me
even
too.
even after her resections, her pulmonary function testing
the
is
hot
still
chicken.
over 100. She's incredible. I know. It's the only one I've ever had.
Scooter
But yeah,
rider.
wonderful.
You're with my good friend Nick,
I think
right?
the old man in the scooter.
Well, most of my patients are riding scooters around the stores. However, every once in a while we get a wonderful one where we can think about kind of complex approaches to disease. Would anybody have thought about doing SBRT potentially for the left side instead of going in surgically and doing additional resection?
I think we would have discussed it for
Yeah.
sure. I think that would be a valid discussion for us.
It's a little more central, but it's possible, yeah.
What's that? Yeah.
And she's got good both, right? Like not, yeah, she wasn't marginal.
Yeah.
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 If these two bilateral tumors had not shown any heterogeneity,
Yeah.
it looked like exactly the same tumor.
Yeah.
Metastatic.
If the thought is, would you consider still doing that even if they were, because
Yeah.
it's technically sort of controllable too.
Yeah, and so we actually talked about that for a long time and how much of a role biology should play in helping to determine these. In a lot of cases where they're starting out as these pure ground glass nodules, with the theory being that maybe this is an adenocarcinoma in situ, which is then becoming invasive. Are those able to metastasize to other places and become AIS? Probably not. These are probably originating, if they'd all been completely solid components, and we thought that these were genuinely metastatic disease, and it's controllable. I think in the era of targeted therapies, immunotherapy, where we're able to control systemic disease in a way we really haven't before, I do think it is now kind of on the table to talk about if we have single site of disease, multiple but controllable, surgically controllable areas of disease, or even a surgical with SBRT combination controllable disease, and we don't develop disease in other places. I think it's completely reasonable to have conversations with really fit patients about doing surgical procedures for consolidative local control.
All right.
Awesome.
All right, perfect. I think we have unfortunately run out of time, so we're not going to be able to talk about adequacy of lymph node staging. We'll meet
Thank you
again.
all for sticking around. That was.
Thank you so much for a
great.
wonderful
Good
conversation.
discussion.
Yeah,
Everyone
that
enjoy
was
the rest of
great.
your conference.
Thank you. That was a good discussion. That prompted a lot.
Great
which is good.
case.
Awesome case. Awesome case.
Great tasting.
Absolutely
That
awesome.
was
Winner.
really good.
This was a lot of fun, guys.
This
Thank
was
you.
a great session. I loved
Yeah,
it.
get the scooter rider.